Great. Well, thank you so much for having me. Just a quick technical question. You can see my screen, but not the Zoom notifications that are popping up, right?
I think only co-hosts have the pleasure of all the Zoom notifications.
All right, just wanted to make sure. All right, so you see my slides. Good. All right, thank you so much for having me. I'm excited to talk about this paper that is joint with Jason and Mauricio and Peter. In this paper, we're going to be asking about the relationship between insurance coverage and health, and specifically, we're asking whether or not individual health plans have a causal impact on health. And the reason we want to ask this at a high level is as follows. In many markets, firms are going to choose not only their prices, but also product quality. And when product quality is difficult to observe, both consumers and producers may make some suboptimal choices and investments. Now, we often, in the context of healthcare, think about this in terms of imperfect information, things like adverse selection. Here, we're just going to be thinking about the fact that it may be hard to evaluate what the quality of your healthcare provider, or in our scenario, we're going to look specifically at insurance plans. It's difficult to evaluate, is this a good insurance plan or not? And by a good insurance plan, we're going to take a very holistic view. We're going to define quality as reduced mortality. So this is not going to be a paper about whether or not consumers are leaving money on the table. You've seen some combination of these co-authors talk about those type of issues. We're going to be asking whether or not an insurance plan can reduce your mortality, whether or not consumers can figure that out, and whether or not they do. Okay, why is that important from a policy perspective? Well, ideally, what would we want to happen in a healthcare market? Well, we'd like competition to lead to some combination of higher quality, lower prices, and/or innovation, right? And so we're going to evaluate whether or not there are differences in quality in insurance markets. And if there are differences in quality, can consumers figure that out in such a way that firms are incentivized to provide high quality? Good. All right, so like I said, then the measurement question is, can your health insurance plan actually make you healthier? That's going to be a tough question for a couple of reasons. So first, consumers of different health will sort non-randomly into plans. Okay? And so because of that, you might want to have something like an RCT, okay, in order to evaluate the impact of health plans when we randomly assign a set of consumers to a health plan. Now, the problem with an RCT in this setting is that RCTs are going to typically be relatively small scale, and thus they're going to be underpowered to detect something like a systematic health and mortality effect. So given these twin challenges, how are we going to think about addressing these issues? Well, we're going to think about addressing both selection and power by leveraging quasi-experimental variation that's going to come about from changes in the choice set, and specifically in our setting from plan terminations. And then we're going to develop a framework that allows us to use the quasi-experimental variation we have to measure the predictive content of the observational mortality estimates. Okay? And so in doing so, we're going to tackle a simpler problem, which is to identify the extent to which we can forecast the true quality effect. And by doing so, we'll add to a large growing literature estimating value added, and we'll think about the assumptions that you have to make in order to do that and link that back to the discrete choice literature. And so I believe we've decided that we're going to put up our research questions and answers just in case my Zoom goes down. And so what are we going to tackle today? So our first question is, do some insurance plans reduce expected beneficiary mortality more than others? We're going to argue that the answer to this question is yes, that there are significant differences across insurance plans, and that these differences reflect true causal variation. The natural next question then is, what drives these plan quality differences, and what might consumers use as proxies? I'm going to show you the things that you might think would predict the true mortality effects, like existing quality rankings, are at most weakly predictive of true quality. Despite that, consumer choice does essentially do better than random. Okay, so consumer choice improves outcomes. Even so, there's substantial room for gains from improved consumer choice, and we'll be more explicit about how we calculate that. Okay, so that's the basic idea and the basic set of research questions. We're going to look at these questions in the Medicare Advantage market. Given the audience and given the time, I'm not going to talk a ton about Medicare Advantage, although obviously happy to answer any clarifying questions that you have. The important thing to think about in this market is that beneficiaries are going to be able to choose from a broad array of subsidized private managed care plans in addition to traditional Medicare. Okay? The private managed care plans are going to be differentiated among a series of dimensions. So they'll have different benefits, including prescription drug coverage. They'll have different networks of doctors and hospitals. They will differ in these publicly available quality metrics. In this setting, that will be star ratings, and they'll have different premiums. Because of generous subsidies in this market, the premiums are sometimes zero. What we're going to do in this paper is we're going to leverage data on the universe of Medicare beneficiaries. So while we don't observe claims from these folks, we do observe their enrollment history and mortality outcomes. And so we're going to use that to construct our estimates of observational mortality and to predict, to measure the predictive content of those observational mortality estimates. I just want to make one point about Medicare Advantage, which is this is a big program, and so you should care about the answer to this question within the context of the program itself, in addition to thinking about the implications for the broader market. At this point, 1 in 3 Medicare beneficiaries is enrolled in a Medicare Advantage plan. Okay? So it's a big, big program. All right. So our first research question is, do some insurance plans reduce mortality more than others? In order to answer that question, the first thing that we have to do is to construct an observational measure of mortality. We're going to construct that in a pretty straightforward way. We're going to essentially regress 1-year mortality of individual I in year T, Y sub I sub T, down on some plan dummies and stuff about the individual consumers. Okay, so the first thing we're going to include is a set of plan dummies, D of I of J of T. So that's going to be equal to 1 if individual I starts year T enrolled in plan J. Okay, the coefficients on that, the planned fixed effects, are going to be what we essentially use as our observational mortality measure. Now we're going to include a vector of very basic individual controls. This will include dummies for age, race, and sex, and critically county and year fixed effects. So the way you should think about this is that we're comparing plans within a geographic market. So we're not comparing a plan in Miami to a plan in Minneapolis. We're comparing 2 plans within the Minneapolis market. Then, of course, there'll be a regression residual, epsilon. Okay, we'll use, because mortality is a noisy outcome, we'll use standard empirical Bayes methods to shrink the estimates of plan health effects mu j proportionally to the degree of estimation error. And so the first thing we see in the data, average 1-year mortality is around 4.7%. And if we plot the differences in those mu's, those observational mortality rates across different plans, we see a substantial variation. So the standard deviation, even once we include our set of controls, is around 1 percentage point, or about 20% of the mean. So that's saying a plan that is 1 standard deviation worse than average is going to have 20% higher observational mortality. That's a big number. And so a natural question is, do we think that that represents the causal impact of enrolling on that plan on your health, or is it just, for example, something about the consumers that we're not observing? Okay, and so that's what we're going to tackle. Okay, so I know that we haven't been taking breaks, but I just want to check and make sure that there are not any, oh no. Sorry. I want to check and make sure that the chat, if there are, nope, nothing in the chat. So I'll keep going and not show you my email. My apologies. Okay. All right. So I promise not to be too cute for my own good. There we go. All right, so we want to evaluate these observational mortality estimates and see to what extent we think they predict the true causal impact on mortality. In order to do that, we're going to leverage some quasi-experimental variation in the choice sets that consumers face. And so several policies during our sample period are going to affect insurer entry and exit. To give you one example, but not the only example, some legislation in 2008 led to the unexpected exit of a lot of large private fee-for-service plans between 2009 and 2011. From previous research, we know that most enrollees in those plans that terminated switched to a different Medicare Advantage plan. Furthermore, we know that absent terminations, MA enrollment is highly inertial. So you should think about a set of consumers who are enrolled in terminated plans who resort into other Medicare Advantage plans, and a set of consumers that, due to inertia, are likely to stay in the plan that they were enrolled in last time. Okay? So this is going to provide variation that's quite useful to us. So I want to walk through a simple example to give you an idea of what I have in mind. We can think about a market with three plans, plans A, B, and C. Okay? Plan A has 5% mortality. We can think about this as the true effect of enrollment in Plan A. Plan B has 3% mortality, and Plan C has 2% mortality. We want to think about what happens when Plan A exits the market. Okay? So if Plan A exits the market, there's going to be a set of consumers that were previously enrolled in Plan A that are likely to switch to the other Medicare Advantage plans in the market. In my simple example, I'm just going to have them sort in equal measure to plans B and C. So now we have a situation where, again, we just have plans B and C in the market, and the consumers who were previously enrolled in Plan A are now enrolled in plans B and C, which again have lower mortality. So what do we expect to happen if the observational mortality is a good predictor of the true plan effects? Well, we would expect that mortality among Plan A enrollees will decline in this example, given the numbers I picked, by 2.5 percentage points. Okay? So let's think for a second about what we've learned and what we haven't learned. Okay, so we see that observational mortality if observational mortality is a good predictor of the true causal impact, we'll see mortality fall among the cohort of people that were previously enrolled in Plan A. But we haven't actually learned the true mortality effect of plans B and C. And to see that, I just have three slightly different scenarios here. Okay, so the first scenario is the one that I showed you, in which Plan B has a 3% mortality rate and Plan C has a 2% mortality rate. I want to compare that to two other scenarios that are in fact observationally equivalent. Two other scenarios that are observationally equivalent are one in which each of Plan B and Plan C has a 2.5% mortality rate, or alternatively, a scenario in which Plan B is the same as Plan A in terms of mortality, 5% mortality effect, and Plan C makes you immortal, right? All of those scenarios are going to be observationally equivalent in the data. So what are we going to do? We're going to write down a model that allows us to relate the observational mortality mu to a true plan mortality effect. And then we're going to use the style of variation that I showed you on the previous slide in order to understand how closely linked those two objects are. Right? To give you the intuition for that, let me just show you a couple of pictures. So in this picture, on the x-axis is time, and on the y-axis is a measure of plan quality for the plan that an enrollee is currently in. So what I've done here is I've split the sample into above and below median observational mortality plans. So the bad plans with higher observational mortality are in red, and the good plans with lower observational mortality are in blue. I've further split those groups into plans that terminate and plans that don't. Okay, now, because of inertia, if your plan doesn't terminate, that's the dotted line, then you're likely to be in the same plan next year, okay, that you were in this year. And so those lines are fairly flat. By contrast, if your plan terminates, you're going to resort probably into a different Medicare Advantage plan, and there's probably going to be some mean reversion. So if you were in a particularly good Medicare Advantage plan, so here in blue, you're likely to end up in a plan that looks more typical in terms of observational mortality, right? A more average plan. Similarly, if you're in a particularly bad plan in red, you'll end up in a plan that's a little bit better next year. Okay, so again, this is our measure of plan quality for the plan in which the consumer is enrolled. So then the next thing we're going to do is we're going to switch the outcome variable on the y-axis. And instead of having something about the plan, we want to follow what happens to the people that were enrolled in these plans. Okay. Again, if observational mortality is a good predictor of the causal effect, we'll see something like what we observe in practice, which is a similar pattern. Okay, so now we have realized mortality on the y-axis. Okay. And again, time on the x-axis. And what we see is that if you were in a bad plan that terminates, you are more likely to be, we know from the previous slide, in a better plan this year. And as a result, you are in fact less likely to die. Okay, and so we see that convergence in the actual realized one-year mortality for the consumers that were previously in plans that terminated. So I think this is suggestive that our approach to validating these observational mortality estimates is likely to be productive. Okay. All right. So what then is the goal of the estimation? Okay. Our goal is to estimate an object lambda, which we call the forecast coefficient. So let's figure out what that lambda object is. We again have a potential mortality outcome for individual I if that individual is enrolled in plan J, Y of IJ. If we randomize people to plans, what could we do? Well, we could just take the average, okay, of the people enrolled in the plan, and we know they're randomly assigned, and that would give us the causal impact of the plan beta J. Now, we don't observe beta J, but imagine for a second that you could regress this unknown beta J on the observed observational mortality mu J. Okay. We're going to call this the infeasible regression. Okay, so now we are regressing this unknown beta J down on mu. We're going to call the coefficient on that mu the forecast coefficient lambda. Our goal is to recover this forecast coefficient from an IV regression. Of course, there's going to be an extra error term, and this extra error term, eta, will come up again in a second. Okay, so within the IV framework, remember that we have realized mortality. Okay, that's YIT. That is going to be a function of the true causal plan effect, some characteristics of the people indexed by XIT, and an error term. Okay, we also have this infeasible regression. We're going to sub the infeasible regression into that realized mortality equation. And our goal is going to be to estimate the mortality outcome as a function of mu J, our observational mortality, plus some individual characteristics in order to recover the coefficient lambda. Okay, now we're going to have these two error terms, one from the realized mortality equation and this new error term eta from the forecast from the infeasible regression. Okay, so what that's going to mean in practice is that we can't just throw observational mortality in there. We need to instrument for it. And the strategy that we're going to use to instrument for observational mortality is really going to mirror that diff and diff style logic that I showed you a few slides ago. Okay, so we're going to instrument for plan observational mortality with the interaction of the observational mortality of the plan you were enrolled in last year and this termination dummy. So TI of T minus 1. So this is going to be equal to 1 if the plan that you're enrolled in terminated in the previous period. We'll also control for direct effects of both of these variables. All right. So let's think through how this is going to work in practice. I'm going to show you this in pictures in a slightly different way. So here what we have is we have the first stage. So this is a bin scatter where on the x-axis I have lagged observational mortality, mu j for a period t minus 1 of the plan that you're enrolled in. And on the y-axis I have this year's observational mortality. What we see, again, I'm going to plot this separately for terminated and non-terminated plans. What we see is that for non-terminated plans, this line is going to be pretty close to the 45-degree line, right? The plan that you were in last period is likely to be the plan that you're in this period. So mu j from last period is a really good predictor of mu j this period. By contrast, the red line for terminated plans is going to be flatter. Why is that? Well, if your plan terminates, okay, and you were in a particularly good plan last year, okay, lower than average observational mortality, you're going to be likely to be resorted into a plan that's a little bit worse on average. And similarly, if you're in a high observational mortality plan, you're likely to resort into a plan that's a little bit lower observational mortality on average. Okay, so that's the first stage. Okay, given the diff and diff style pictures I showed you, you should be able to think through that the reduced form is in fact going to look pretty similar. Okay, so now rather than having concurrent observational mortality on the y-axis, we have the realized outcome. Okay, and so what we're going to see in practice is a very similar pattern, which is going to indicate to us that observational mortality is a pretty reliable predictor of beta j, the true quality of the plan. Okay. This basic visual setup also allows us to evaluate the critical assumptions that we'll need for our estimates to be valid. So remember, we have these two error terms floating around. We have epsilon, which comes from that realized mortality equation, and we have eta, which is going to come from the infeasible regression. Okay, so the first thing we're going to do is we're going to think about epsilon. Epsilon you can think of as sort of the standard exclusion restriction. We're going to need something like the beneficiaries in terminated and non-terminated plans are similar, conditional on lagged mu. Okay, and so that's what we're going to think about now. And in order to evaluate that, I'm going to present the equivalent of a balance test, where what I'm going to do is I'm going to replace the actual outcome we're interested in with a predicted mortality outcome. So this is just an index of demographics that I observe. And I'm going to say, hey, look, if you're in a high or a low observational mortality plan, does it look like on observables, those enrollees are sicker or healthier depending on whether or not that plan terminates? What we see in practice is that that's not the case. Okay? So there is a sense in which higher observational mortality plans do in fact have sicker enrollees, but that is not differentially true for terminated and non-terminated plans. Okay, so that gives us some confidence that we're going to be able to recover the true causal effect. Or, sorry, I misspoke. That we're going to be able to recover the forecast coefficient. Okay, but we also have this eta term floating around. This eta term is going to be a bit thornier because it's going to ask us, do people in terminated and in terminated plans sort into new plans that are typical in terms of their eta? Okay. I don't think this is the most intuitive condition in the world, and I'm happy to talk about it in the author room in a bit. But what I can tell you is that the fallback condition can absolutely be microfounded. It will be satisfied in a broad class of discrete choice models that you are familiar with. And that provides some guidance for what we need to control for, depending on where you think the consumer heterogeneity affects choice. It also provides some guidance in terms of creating a equivalent to that balance test that I showed you from before. Remember that what we're going to need is that our instrument is uncorrelated with eta. Because we don't observe beta J, we can't compute eta J, but we can construct proxies given plan characteristics. So just as the balance test provided some information about individual characteristics, we can test something about the plan characteristics of the plans that consumers are likely to enroll in. Okay. And when we run that balance test, again, we're going to have a picture that looks similar to what we had for individuals before, where for terminated and non-terminated plans, there is a pretty flat relationship, and it's consistent for both terminated and non-terminated plans. Good. What does that mean in practice? Well, it's going to mean that we're going to get a forecast coefficient pretty close to 1, which means that observational mortality reliably predicts the true mortality effect. I want to be clear that that doesn't mean that there's no selection bias, but that we can construct a good proxy for the true mortality effect. And again, you can see this in the earlier panels in this table by dividing the reduced form by the first stage. Okay, and our first stage is fairly strong. Okay. What does that mean? Okay, well, I said that observational mortality reliably predicts the truth. Variation in the true effects is at least as large as in observed mortality mu J. Okay, and so these are big differences across plans. So how should I think about that in the context of the literature? Well, we can compare it to a variety of estimates from the literature, to extensive margin estimates of the impact of getting insurance, whether in the Medicare or Medicaid program. We can think about this in the context of place effects, moving from the 10th to the 90th percentile appears to be associated with a 30% mortality reduction. And we can also think about aggregating this up from the underlying effects of hospitals to the extent that there are differences in networks, something that we touch on in the paper, but there's much more to do. We know that there are big differences in hospitals, and so to the extent that plans direct consumers to different hospitals, that can lead to big differences. All right, so now that I have shown that some plans do seem to reduce mortality more than others, we're going to think about the extent to which we can capture what drives those differences and then talk a bit about consumer choice. All right, so we want to think about observable plan characteristics. We want to think about the extent to which they are correlated with either observational mortality or the true mortality effects. That's not to say that these are causal. So if I moved you into a plan with a lower drug deductible, that would lead to lower mortality, or alternatively policy invariant, right? If I made everybody offer more generous drug plans, that would reduce mortality. But at least it is a start for thinking about what is driving our results. The basic intuition for how we're going to get at these mechanisms is that in the forecast regression, we can substitute any plan attribute for mu J. So what I've shown you so far is that mu J does a good job predicting the true causal effect. Okay? We're going to think about the extent to which other plan characteristics might do the same. All right, when we do that, we see that things like star ratings are positively correlated with observational mortality. That's a little weird. You might expect it to go the opposite direction. We also see that plan financial characteristics like premiums and donut hole coverage and MLRs are correlated. But what's interesting is when we run the actual IV regression. When we run the IV regression, the coefficient on star ratings is statistically insignificant. But what we do see, so just to be clear, that means that star ratings are not a particularly good proxy for the true causal impact of plans. But what we do see instead is that the plan financial characteristics seem to play an important role. And the way I would summarize the results in columns 2 through 5 of this table is that plans that seem to spend more also appear to have lower betas. Okay, and to see that, we can see that higher premium plans, lower true mortality effects, donut hole coverage, higher medical loss ratios, the higher the percentage of the premium that you're spending in claims. All of these things I think are consistent with a story where the overall generosity of the plan is associated with the true causal impact on your health. Okay, good. All right, so what's interesting here is that I've told you that the publicly available star ratings are actually not a very good proxy for what's going on in terms of true mortality effects. And so that raises a natural question, which is, can consumers observe these things and can they sort appropriately? This is important for thinking about the value of consumer choice in improving health outcomes. It's also important because if we're thinking about the insurer's incentive to invest in creating a plan that reduces mortality, if consumers don't value that, they're not going to have an incentive to do so. Okay. Now, the key insight to get a measure of consumer willingness to pay for true plan quality is the same as what we talked about when we thought about mechanisms. And that's the idea that I can replace any variable for the observational mortality in our IV regression to understand the correlation between that variable and the true mortality effect. Okay. We also know from the standard discrete choice literature that we're going to be able to invert market shares to recover mean utility. So this is the standard Berry 94 log share minus log outside share equation. And that's going to allow us to think about consumer preferences for plans as a function of things like their true quality effect beta J and premiums. Okay. Of course, beta J is unobserved and may be correlated with premiums, but given a price elasticity, and we're just going to take some off-the-shelf price elasticities and therefore an implied premium coefficient, we can use our IV framework to implicitly regress beta on delta minus alpha times the premium. What is that object? Well, it's just the weight that consumers place on beta J times beta J plus phi. Okay, and so this is going to allow us to bound consumer willingness to pay, okay, for a 1 percentage point decrease in plan mortality effects. All right, when we do that, what do we get? Well, we get that depending on your assumptions on premium elasticities, the maximum consumer willingness to pay for quality is positive, so that's good. And you know, it's different from zero. Okay, it's not necessarily huge, right? And so when I say not necessarily huge, what do I mean by that? Well, I mean it's actually quite big. To say you're willing to pay you know, $200 a year to reduce to shift into a plan that reduces mortality by 1 percentage point, that's actually really big relative to the average premium in this market. So I think that kind of makes sense, but it's very small relative to, for example, the value of a statistical life. And so put differently, these considerations about the impact that a plan has on your health should really trump anything else that's going on in terms of the plan, in terms of how consumers evaluate those plans. We see that consumers place some weight on these plan characteristics, but quite frankly, not enough relative to how big we think the impact on your health is likely to be. So I know I'm running short on time, but I just want to sort of say in terms of simulations, you can think of a variety of different ways of using simulations to both characterize how we think about the magnitude of our results and to possibly think about alternative policy implications. I think the main takeaway here is that there are large potential mortality reductions from better aligning quality and plan choice. Why is that? Because we see big differences in observational quality across plans, and we know that that observational mortality predicts the true causal impact. Taking a step back and thinking about this at a high level, why do we think this is important? Well, we want to think about the extent to which competition can discipline healthcare providers and insurers. We know that quality is going to be especially difficult to observe in healthcare markets, and difficulty measuring quality will make the expansion of high-quality firms more difficult. We want to not only shift consumers into plans that are likely to improve health outcomes, but also to give insurers incentives to invest in those plan characteristics or those systems or processes that improve consumer health. Our initial simulation results also indicate that policy can improve equilibrium outcomes. There's plenty of disagreement amongst the co-author team about what that optimal policy might look like. At the very least, we think releasing risk-adjusted quality measures for plans in a way that is similar to what we currently do from hospitals has some real value. So with that, I'll turn it over. I'm looking forward to the discussion and Q&A and the author room.
Okay, great. Thanks so much to Amanda as well as Jason for giving me the opportunity to think more deeply about this paper. It's a really well executed paper and on an extremely important topic. I chose this as kind of the unique title slide. Just as a way to show just how important this could be. So Yale Insights had this paper, choosing the wrong health insurance could kill you. And with this graphic, if you choose door A, things are great, you'll get across. There are some barriers, so you don't fall in. If you choose B, you might fall in. There's kind of a missing rung. And if you choose C, then you get fed to the sharks. Those being the health plans. Okay, so I think this paper is kind of on its way towards submission and publication, so I wanted to just drive home to at least the audience the importance of this setting, and then focus on a little bit of bigger picture comments and maybe suggestions for future thought or work. So the importance of the Medicare Advantage setting. So regulated private health plans are a major form of social health insurance in the US these days. So Amanda mentioned that 1/3 of Medicare beneficiaries are in one of these private plans. If you go to the Medicaid system, it's 2/3 of plans, and all of Medicare Part D are in these types of plans. And these plans are actually quite controversial. So one of the potential benefits of them are that they allow more choice. And by allowing that choice, plans could be tailoring their quality to patients' particular needs, and that might reduce costs, and that might be a good thing. On the other hand, they may cream skim healthy beneficiaries or potentially even skimp on quality in order to kind of reap the financial gains. And that could be a problem, particularly if oversight of these plans is somewhat lax. And so in a lot of this controversy is the idea of quality swirling around. And so understanding that distribution of quality across plans seems to be first order for policy. But of course, this is very difficult. And so that's what this paper is trying to get into. So just a quick summary. There's huge variation in one-year mortality across MA plans. So a standard deviation, higher quality plan decreases beneficiary mortality by 0.9 percentage points. So there's on average around a 5% mortality rate, and that's a 19% reduction. So that just seems huge. And so one of the difficulties of this paper is trying to tease out whether this is just due to selection, meaning are healthy and sick beneficiaries just sorting into different plans, or is it due to causal effects of the plan? And so most of what they're finding is that a lot of that is actually causal. And to get at that, so to purge these selection effects, they're taking advantage of exogenous plan terminations. And the intuition is somewhat of a regression to the mean type argument, where individuals in higher mortality plans that terminate are likely to move to less high mortality plans. If they still died at those higher rates, that's some evidence of selection. If they don't, then it's causal effects of the plan. And they carefully lay out the assumptions needed to get there, including this kind of extra fallback condition. I'm not much of an econometrician, so I will stay farther away from that discussion.
I'm sorry to jump in. Do you want us to be looking at your title slide?
Oh my gosh. What do you see?
The title slide.
I don't know why that would be. Thank you, Amanda.
It might be that you're not sharing the full screen. You're sharing the window. I don't know.
I don't even see. Oh dear. I don't even see where I can change it now. Okay, I just stopped. Share. I will just share a screen now. What do you see now?
Now I can see the summary.
Oh my gosh, thank you.
Okay.
Okay, so, all right. Thanks, Amanda. Okay, so it turns out that these causal effects are uncorrelated with star ratings, which is a little bit alarming if you think that people are choosing their plans based on the star rating. Okay, let me jump ahead since I now don't have much time. So I went and looked at how you actually choose plans. In these types of papers, I'm always curious how you would actually choose these plans. Here's Dane County. We have around 30 that we could choose from. Curiously, if you sort plans, you see the ways you can sort it are all about costs. They're not about quality type measures. If you then click through the various options, it's again all about cost. There's a little bit about star rating right at the top, but it's not super emphasized even. So it's kind of telling us that we should be thinking about cost potentially as opposed to quality. Okay, so let me jump into my comments. My first one is about who are we actually talking about here? So first, whose mortality is affected across these plans? So are the people who are differentially dying, people who are marginal, so people who are likely to die soon and potentially going into a better plan just pushes your death back by a little bit? Or are these kind of catastrophic differences, meaning that people otherwise would be dying a decade later, but death is a decade earlier in plans that are poor quality? And so I think this could have different welfare implications based on which types are dying. And I'm wondering if you can investigate that using something like longer horizon mortality, such as 2-year mortality rates. And then also just who chooses these plans poorly or well? Is it, are there particular subgroups that are better or worse at choosing MA plans? The dementia population, a lower income population, and if these are particularly vulnerable populations, perhaps we're even more concerned. And those also could affect the interpretation of welfare estimates. Okay, second is the relationship to traditional Medicare. So you don't talk about this that much in the paper, but do you have a sense of where traditional Medicare falls in the mortality distribution? I think this could be relevant to the debate on the merits of Medicare Advantage over traditional Medicare. Can you use a similar strategy to estimate these effects? Is traditional Medicare something you can choose if your MA plan terminates? And actually, is it a default? I'm wondering if there's a default in when your plan terminates. What happens if you don't actively choose a new plan? There's a lot of inertia, as you talk about, and I'm wondering if some people are inertial in terms of just not choosing anything. Okay, and then my final comment, I know I'm probably over time now, is what is quality? And I don't actually mean this in kind of an annoying way, but this paper defines quality as reduced mortality, which of course seems like one of the first order aspects of quality, but I don't think it's the only one. So Jason Abaluck, who's actually one of my dissertation advisors, so I think I'm allowed to say this. In that Starc piece, he says, let's reimburse plans based on what we actually care about, which is whether they make people live longer. And I'm not sure that's totally true. I think we care about other things. In the paper, what is mortality missing? It could be missing morbidity, which might exacerbate not exacerbate, but your quality measure might be underestimating actual plan quality. But finally, and I'll just end here, we might be thinking that we might wonder whether quantity of life or keeping people alive is not what we're interested in. We're interested in quality of life, particularly at the end of life. So maybe we'd actually like to prioritize patient desires in end-of-life decisions as opposed to extending their life. And so maybe you could look at things like how mortality measures are correlated with, say, hospice care or hospice spending in these MA plans. I will leave it at there. Thanks. Thanks for a great paper, and sorry about the technical challenges.